Good morning, everyone. the weather.
Okay, let me text him and find out if he's still.
I'd like to call the January 2024 meeting of the Indiana Emergency Medical Services. Please have determination of quorum.
Matt Shady,
Here.
Brian Herwick, Darren Hoggett,
Here.
Lee Turpin,
Here.
Jerry Harder.
Here.
John Zartman,
Here.
Dr. Brown,
Here,
Matt McCullough,
Here.
Andrew Bowman,
Here virtually.
Marianne Dudley. Bassett,
Here. Thank you. Everybody, would please face the flag, pledge allegiance. Pledge of allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Before we move to make an announcement regarding quorums.
And I know we've sent emails over the summer. I just wanted to give a little reminder to everyone that almost had a little mini heart attack this morning when I got here and realized maybe with the weather, people may have like changed their RSVP to being virtual. So just as a refresher, and this is all in Indiana state law. I know when we had, the emergency with COVID, the remote participation was just allowed because it was like a state these meetings are allowed to be hybrid, so people can be. But there are still minimum requirements that that 1/3 of the members must be in person at all the meetings. So for this body, that means 5 people must be here in person. That's just state law. So just a little refresher, like when we're RSVPing, just. As if we don't, then we don't have quorum, and then everyone would have to go home, and I don't think. So, I might. Knows that that's the rule, so just want to remind everyone of that. Thank you.
And if I recall,
All the members, just so everyone's aware that that's the laws. And yes, you're allowed to be virtual, but you must at least be at 50% of the meetings in person. So when you're kind of gauging out your calendar year, maybe keep that in mind.
Thank you. Moving to adoption of minutes, pleasure of the commission.
motion to approve. Second.
Motion to approve and second. Any further discussion? Can we have a roll call vote?
Matt Shady,
Aye.
Brian Herwick, Darren Hoggett,
Aye.
Lee Turpin,
Aye.
Jerry Harder,
Aye.
John Zartman,
Aye.
Dr. Brown,
aye,
McCullough,
Aye.
Andrew Bowman,
Aye.
Lori Mailey, Joe Becker.
Aye.
Motion approved.
Minutes have been adopted. 2023 meeting. Honorary certificates.
No action needed on these. You can see a little bit quiet over the holidays. We have a few process began this year. They'll show up next month. They are listed there for your review.
Thank you. Moving on to reports, Indiana Department of Health Trauma Systems.
We did have a state trauma care commission meeting, held their second meeting, and as you recall, Director Thacker is one of the members there. They went over kind of their big project is their grants, which they did have a couple of applications that included an EMS component. And then they did hear from Dr. Yazel and I on kind of what we're doing for EMS. Still really interested in tracking interfacility transfers as it impacts and trauma and outcomes.
On to legislative update, Director Kinney.
Okay, so for our legislative, we are in legislative session. I will give a little bit of a reminder with regards to that. This body is part of the executive branch and so therefore is under the governor's office. So one of the things I would remind is that if you are representing the commission, we do seek approval if you are going to comment. So if you get asked to make a comment or testify on something, I would not identify yourself as a commission member. Occasionally you may get asked in your other capacity of position or something. But just remember that we do ask for that. And we ask that you notify our office legislative director. And I'm not saying they will tell you what to say or stifle you. They just have to get permission for you to be able to comment. So please keep that in mind. These are updates. These are, I always comment. I used to cover part of this, but it is not, I'm not our legislative director. If we have questions, we can ask Alyssa to comment on those. Alyssa Schroeder has done an excellent job for us for a number of years. But I do this as a service to the EMS Commission. That is the link, and I will email out my presentation too. And I did email out a report on this, and it has the link if you want to check bills. The deadline to submit bills had already passed last week, but the way they go through and they are processed by the government office, sometimes they fall later, so they're trickling in. And so there could be a couple of new bills that I do not have on here. It is a short session, no budgetary items this year. And so really coming up by February 5th and 6th, they have to pass the first house in order to be eligible to go over to the second house. And then a month later in March, then they would have to have final passage. So things are moving very quickly. The bills that I thought I would highlight for you are House Bill 1118, Healthcare for First Responders. This requires FSSA to develop a program to cover first responder mental health treatment. So if someone seeks treatment and says, I don't have the funds for it, they would apply through an FSSA program. Most of these are all at this point have not been passed. They are just assigned to committees. So these again, doesn't mean they would be. Who's your first responder medal self-sacrifice? That requires us to have a program to recognize first responders seriously injured or the deaths in the line of duty. So that would include law enforcement, fire, and EMS. Both fire have one that goes through the fire marshal's office. And then, as you know, we have designation. And so Alyssa has reached out to the author of this and said, just so you're aware, we do have existing. We aren't saying we aren't opposed to doing something if the legislation would pass, just that there is existing. So we don't know if this will proceed or how that will be dealt with. House Bill 1302, Emergency Medical Services. This is a bill that would require the county executive to report to IDHS information on EMS coverage in their county, answer questions that we pose to them. IDHS would be required to create a report by this summer, compiling all that. And then the request would be for a summer study commission. And the summer study commission is going to look at the essential function or essential purpose, like who should be providing EMS, what's the minimum coverage, and so they would take a deeper dive. So rather than trying to pursue, and this came from the Professional Firefighters Union, rather than try to push through any requirements, the request is to study the issue and see if it's sufficient and are there needs, which I think we all believe there are needs for clarification of that. House Bill 1378, coverage for MIH services, that requires health plans to cover MIH performed in Delaware, White, and Montgomery County for a 3-year period, and for Department of Insurance to compile a report of that coverage and usage of MIH. They didn't label a pilot program, but it kind of sounds like a pilot program to look at funding for MIH programs. I should note at this point, IDHS has one bill and it has no EMS content, and it has to do with other items within the agency. So none of these are our bills when I speak about them. House Bill 1385, payment for ambulance services, is a billing item. I don't know, you may hear more, sometimes the EMS Association updates in their report. They tend to track the deeper dive into billing, but it's out there if you want to review that. To me, with my understanding of billing at this point, since I haven't done it for a decade, it seems to address, the requirements for fair billing between EMS providers and insurers. Senate Bill 54, Marion County Fire Consolidation, and that is a bill that looks at bringing eligibility for Wayne Township Fire to be added under Indianapolis Fire Department. I list this because while it is a fire service bill, that would include coverage of their EMS because they are an EMS provider. And so we could see impact there. Senate Bill 60, safe haven for infants. The big changes there is that they want to require EMS to transport child not in a hospital to a hospital if there is a call on them, and also want to create an EMS registry that's accessible for the agencies to report. So for instance, if EMS does a safe haven, a baby box call, they would then log it in the system with that. I apologize, I didn't write notes. I think that would be on FFSA to do the registry on that. Coverage for MIH services requires a state employee health plan to cover MIH services. So that would be, and you sometimes see that as a precursor, because if you change the state, then the hope of other employers would follow. Senate Bills 296, 297 are deal with administrative proceedings. I'll just say that there is still concern with the legislature about administrative rules and the weight that they can carry and the process and the oversight that goes into it. So we have found it challenging from this body, but there are a lot more controversial, but these would impact us. The 296 will be one to watch. It has a lot of big support, several co-authors. That would say that OALP would be the final determinant for any hearing that they hear. And so if the EMS Commission continues to use OALP, then you would be putting a trust in them. And instead of having a non-final order, their orders would be final. And so that's something we would review. Right now, as you know, we changed it a little last fall with the General Counsel and Hillary advising us on certain matters, and you're going to hear one today where we did an agreed one. And used to on the agreements, they would come back for the commission to approve. But the decision was if it's under appeal, if the ALJ feels the agreement correctly resolves, that is the final action. So we'll have to watch both of those, but that is the climate that is out there on looking at those administrative proceedings. Those are the bills that I saw right now that I thought the commission should consider tracking. I am open to any questions.
I think on the administrative rules regarding $1 million threshold, there are some carve outs that I think involve like safety concerns, fire. There were, it looked like possibly some public safety carve outs that if you were having administrative rules for certain things, that new law doesn't exist. So we'll have to monitor that as we move forward, as it may affect the commission. We may be required to follow that law, or depending on what rule is and how it's recognized, it may be able to be excluded. So TBD on that moving forward. So
Thank you. It crossed my mind because when you get into safety and you multiply the number of either providers or ambulances out there, it can add up to $1 million.
I missed the bill number for the one about mobile integrated healthcare, the state employer having to pay. What bill number was that?
142.
Thank you.
No further questions for Director Kinney. EMS for Children, Margot Knupp.
I mean, this is a little bit ago, said she couldn't be here. I said if there's anything you want us to report, let's see. It says the EMSC EMS assessment is launching in May, plans to share more on social media and in the Hoosier Responder. See, IMSC is in the beginning stages of designing a pre-hospital pediatric readiness program. A core group will begin next month looking at national programs in existence and best practices to design a 2-tier program in Indiana. That's what she just sent me.
Moving on to Indiana Fire Chiefs Association, EMS Division.
Didn't see.
and I want to thank 1302 is actually a fire chiefs. It may be a joint PFFUI Fire Chiefs Association bill. So it's not, it is, as Greg said, not one of our agency bills.
He's not online. Okay.
And the fire chiefs is very active. They've been active in several of our projects. You're going to hear about our Indiana EMS 2025. They've been active there, both with Jared and also with Chief Danny Singh. And I know their big thing is getting ready for their conference, and they did announce they are moving. It'll be the first week of October. I can look up the dates, and they are going to be in Noblesville this year. So it'll be a new location for them versus it had been at Keystone Crossing for a while, went back to the Marietta East, and now it'll be up in Noblesville for this year. I think those are their big projects.
Indiana Emergency Medical Services Association. Very well.
Good morning.
Craig informed you the legislative session is going on, and obviously that takes up a lot of our time. Kim Godden's going to speak briefly on that 1385 bill that we had talked about. The main thing that we have coming up right now is we are accepting nominations for both the Provider of the Year Awards and the IAMSA Golden Siren Awards. The Golden Siren Award is for those who have served in EMS for 25 years and have made a significant impact in the EMS in the state. The Provider Awards are for EMTs, paramedics, educators, dispatchers, agency leaders, and services. The deadline for this is approaching quickly, so we really ask, especially on the Golden Siren Awards, if you could give us the nominations soon. You can do so by going to our website and on the cards that Again, the deadline for that's fast approaching February 16th. We do have changed our dates for the conference, or I should say changed it. We set the dates for the conference for 2024, which will be November 20th, 21st, and 22nd. Our conference has traditionally been the week after Thanksgiving, but the way the calendar falls this year, we moved it to the week before Thanksgiving. So again, those are November 20th, 21st, and 22nd. And Kim Godden, our legislative chair, will talk about the bills.
Morning, everybody. Kim Godden, Legislative Chair for the Indiana EMS Association. Mr. Kinney had already talked about House Bill 1385. Just wanted to give everybody an update on this bill. In October of 2018, all of us, fire service, private, nonprofit, hospital-based, every ambulance company in the state of Indiana received a letter from Anthem Blue Cross Blue Shield, now called Elevance. In October of 2018, that letter said that whether you're in network or out of network, you're going to be paid this rate. And that is what, in essence, created a balanced bill to all the patients. And we, through our association, we attempted to pass some legislation. Initially, there was a movement to move us into prohibition of balanced billing. All of us got together, we were able to stop that. That was right before the pandemic. After the pandemic, we were able to pass some legislation just requiring insurance providers to fairly negotiate. We developed 9 criteria. Those 9 criteria that any insurance company would have to negotiate with the ambulance provider. Take a look at what the rates, the labor rates are in the region, what the service levels that are being provided, response times, certain metrics to be able and to negotiate a fair reimbursement rate. Unfortunately, that legislation passed, went into law, and none of the commercial providers adhered to the legislation and used any of those criteria to negotiate. Dr. Barrett, Representative Barrett, is introduced this bill this year, which is going to set the reimbursement rate to either what the charges are. So if a local community has a set charge, so if a fire department has a set charge or a community has a set charge, which many of you guys know we have to have based on costs for that Medicaid share. In the state of Indiana, public providers can receive their full costs from the federal government for Medicaid transports. So that Medicaid number is out, that cost number is out there for Medicaid. So this legislation says that the commercial, if we cannot reach a fair negotiation, right, with the insurer, if the insurer does not want to negotiate a rate that we're all happy with, the insurer has to at least pay the set rate that's set by the local ordinance or 500% of the Medicare reimbursement rate. The bill goes to committee next Wednesday. We don't have the time yet. I don't believe we have the time yet, but we will share it with everybody. The chair of the committee, it goes to the insurance committee. The chair of the committee and our bill sponsor would like to have as many individuals in the room as possible to support this endeavor. Again, all we're looking for is fair reimbursement. Right now, based on this fee schedule, the state of Indiana's Medicaid pays us more than what Anthem's commercial insurance does. And many of us recognize that what happened during the pandemic when you were transporting a COVID positive patient, the federal government prohibited balance billing. We saw commercial payers paying even less because they knew there was nothing we could do. So at a time when we've got an EMS shortage, right? We know, as Mr. Kinney reported, we're looking at trauma and our trauma system throughout the state. We need to encourage more individuals to stay in EMS. And when Amazon can pay more, right, it doesn't help us. And that's by and large because of what's going on with commercial insurers. So encourage everybody, if you have any questions, please come reach out to me, get me an email or reach out to the Indiana EMS Association, ways that you can be helpful on this legislation. Thank you. Yeah.
I have a question. I think you may have answered it later in your comments.
Sure.
I want to know if Blue Cross Blue Shield gives an amount and what is it for what they will pay?
This letter in 2018, for ALS emergency code A0427, they said they were paying $477. The Indiana Medicaid rate, since we got an increase, pays more than that. So that's pretty telling.
That is.
And in many cases, they pay that to the patient, not to the
Exactly.
provider.
Good point. Thank you, Lee. Thank you, Chairman. In many cases, if you're out of network, they pay that money to the patient and then the ambulance provider has to chase that money from the patient.
Is EMS Association, is this you working with Representative Barrett then on that bill?
Yes,
Thank you, because I know the original, you referenced that Medicare pays that amount, but that's because of the work you guys did a few years ago as well. It's the only reason the Medicare rate is up.
correct. Yes. Now we've got Medicaid parallel to Medicare, but as we all know, Medicare pays below our cost. And that's why as a country, we're going through cost data collection. I could go on for hours and hours about this, but as we all know, there's 5 codes and there are more than 5 patients. And in 20 years ago is when we set our fee schedule, and the world has changed a lot in 20 years. So that's why the federal government has us going through cost data collection. Something that everybody should remember though is hospitals get paid on a cost report. So hospitals, that's how Medicare pays them. It's reflective of true cost. It's reflective of how much uninsured they get. EMS is very similar to an emergency department where we treat anybody. We don't know. We're not a dentist that can say, hey, pay up front before I fill your tooth. We are showing up and providing service, and on the back end don't know whether they're insured, underinsured, self-pay, Medicaid. We're there for the right reasons, to save the patient and in the middle. So thanks everybody for your time. We really appreciate any help you guys provide, because this is something we all need to be a part of. The insurance company has got a lot of the insurance industry has a lot of individuals out there. By and large, they have a lot of money to spend. We have all the statistics and criteria of how much money that they've made. We know it's less than 1/3 of a penny is what ambulance cost is to an insurance provider. So we're small, we're budget dust to them, but it's a really important part of the healthcare system. Any questions? Yeah.
Your previous legislation, do you remember what that bill was?
Oh, I'll get it for you. The previous, there were 2 other bills. I'll get those for you. I don't have them off the top of my head right now.
Was that in 22?
It was in 22,
Yeah.
correct. And what it was is I can give you the bill number, but it ended up coming into the concurrence bill. Yeah, so I can share that with you. That was what set the criteria. Thanks, everybody, for your time. Appreciate your support.
Education Oversight Committee, Commissioner Sutton.
Mr. Chairman, we have a meeting, I believe in 2 weeks, I think it's on the 2nd, to start working on the advanced EMT and EMT psychomotor aspect. So have a report for the next commission meeting.
Mobile Integrated Health Committee, Director Kent.
You, we did have our meeting on December 8th, here at May. We continue to have really good turnout. It rivals the full EMS commission, the amount of turnout we have for Mobile Integrated Health, which is great to see that many providers engaged in it. We will have recommendation for approvals for Deaconess Franciscan Health, Crown Point, and Gas City. We're going to hear about. FSSA did designate a new person. We had a little bit of turnover there. We are going to have Dr. Ty Sullivan will be on the MIH committee from FSSA. We heard about Bloomington Fire Department on their extensive community work on with their MIH program. And then we may be looking at doing some MIH offerings through either the EMS Association Conference or through IERC or both, targeting MIH to try to create more of a way for the providers to come together, get education and share what is working. Our next meeting will be on February 9th, 10 a.m. out here at May. And I will turn it over to Emily Casper, who is online today, and who will be presenting on the applications for MIH approval.
Good morning. Okay, so like Director Kenny said, we did just have a meeting on December the 8th. We will go over the programs that applied. The application process is still the same. If you go online to the MIH website through DHS, you'll be able to find a link to the application. The requirements are the same as well. Our applications this time around are Deaconess EMS, Franciscan Health Crown Point EMS as well, and Gas City Fire Rescue. My apologies. So first is Deaconess EMS. They are in District 10, covering Vanderburgh and Warwick counties. They will be providing hospital dismissal, post-discharge follow-up, and readmission prevention, as well as diabetic counseling and monitoring, chronic disease management, decreased utilization of the EMS by high-frequency patients, elderly management programs, including falls, immunization and vaccination initiatives, as well as child passenger safety seat inspections. So the goals of this program, they would like to achieve a decreased admission into the healthcare system, as well as decrease problem areas such as at-risk patients, and ensure patients get proper follow-up care after being discharged from the hospital. Their education requirements, in addition to standard Deaconess health requirements, will be adding a child passenger safety technician training course as well. So our second program is Franciscan Health Crown Point EMS. They are located in District 1, covering Lake County. They will be providing hospital dismissal, post-discharge follow-up, and readmission prevention, as well as post-response follow-up for certain emergencies such as diabetic and overdose, diabetic counseling and monitoring, chronic disease management, decreased utilization of EMS by high-frequency patients, substance abuse mitigation, mental illness mitigation, OB newborn management programs, elderly management programs, including falls, and immunization and vaccination initiatives. So the goal of the program is to work with the hospital at home program. They will be bringing field care to patients who are enrolled. They would like to partner with local agencies for community risk reduction programs and bolster MIH and community paramedicine initiatives in Northwest Indiana. In addition to their standard licensure, additional training for home and risk patient assessments will be performed internally, so they'll be training on those two assessments. Potentially adding NAEMT's community paramedicine course to the department's course offering. Franciscan Health Crown Point EMS will currently have established trainings for mental health, car seat clinics, back to sleep, stop the bleed, and Narcan training. Our final program to review is Gas City Fire Rescue. They are located in District 6, covering Grant County. They will be providing hospital dismissal, post-discharge follow-up, and readmission prevention, post-response follow-up for certain emergencies, such as diabetic and overdose, diabetic counseling and monitoring, decreased utilization of the EMS by high-frequency patients, substance abuse mitigation, OB newborn management programs, and elderly management programs, including falls. So their program, their goal is to provide care for those who are unable to maintain or obtain their own care services, either bound by age or mobility, or due to financial restrictions, while providing necessary information for additional resources if higher level of care is necessary. They will also provide training to those in need of hands-on experience with new medical equipment, such as respiratory or diabetic equipment. All personnel included in the program are trained accordingly per department policy of minimum training requirements.
Thank you. I do not know, and so let's see, do we have anyone representing Deaconess in person or online that would like to add anything on their application?
We have some online.
Hi, it's Angela Smith and Shelley Rogers. We don't have anything to add other than what's there on the slide unless you have any questions for us.
Thank you, we appreciate it. Franciscan Health Crown Point EMS, anyone in person or online that would like to add anything on the application? Final one, Gas City Fire Rescue. I think I will point out, they actually were of the MIH grants were the one provider that we denied because they didn't have a defined program. I want to commend them because they went out and they defined this program. They now have it here for approval and they are very interested in the next grant cycle. Is there anyone from Gas City Fire Rescue in person or online that would like to add to your application? Okay, the MIH committee did review all three. It is our proposal to recommend approval for Deaconess EMS, Franciscan Health Crown Point EMS, and Gas City Fire Rescue as approved MIH providers by the EMS Commission.
Motion to approve.
Second.
Motion to approve, a second. Any further discussion? All in favor? Roll call vote.
Matt Shady.
Aye.
Brian Herwood. Darren Hoggett.
Aye.
Lee Turpin.
Aye.
Gary Harder.
Aye.
John Zartman.
Aye.
Dr. Brown.
Aye.
Matt McCullough.
Aye.
Andrew Bowman.
Aye.
Marion Dudley.
She's there.
She got one. Dr. Nassif.
Aye.
Lori Maley.
Aye.
Joel Thacker.
Aye.
Motion approves.
So that's our update. As I said, our next meeting will be February 9th out here, and anyone is welcome. We do have virtual link. Emily can send out if anyone would like to participate virtually. That's all I have on MIH unless there's any questions.
Moving on to new business, reciprocity requirements discussion, Director Kenny.
So this is something that I am bringing because I know the commission appreciates, and you guys are the body that is made up of our experts that kind of think through things. This is an issue that I've seen for some time that's just kind of sat there, and I've scratched my head a little bit. And with the EMS compact, I've struggled a little more and talked to other state directors, and that's how people move from state to state and what barriers we have and whether they are appropriate barriers or not. And we do get requests on, why can we not speed up processes? And I think this is an area that's open. So I have a thought that maybe we want to either grant a general waiver or not, but I would like to hear the commission discussion on it. So what is reciprocity? Reciprocity is basically recognition of credentials from another jurisdiction. Example would be for in NAMC, we accept NAMC, National Association of EMS Educators, their instructor course. You don't have to take Indiana's. It's a quality course. If you take the national course, we recognize it. That's a form of reciprocity. What is the difference between National Registry and our Indiana? And as I've learned it, you will hear me use it a little more, but I haven't pushed to change the culture because, for instance, if you look at all of our code, it talks about certifications and such. Really, what we issue are all licensures. Certification is basically going to be when you take kind of a snapshot, you meet minimum requirements and you're good to go from that day. The licensure means that a body that is so authorized has given you the. And so in the attorney's field, we are both lawyers. Hillary and I are both lawyers, and Kim. That means we graduated from law school. But there are many people that may not, I shouldn't say many, but there are some that never passed the bar exam. And so they cannot practice and use what they learned there. Once you pass the bar exam, you become an attorney, which means then you can actively practice using your law degree. And I think that's a good example of how the National Registry works. It gives us the tool that we can go on, but there's no state that says you can practice on your National Registry. There are states that say when you present it, we'll recognize it and you have a state authorization. But generally, I can't just take a National Registry and go anywhere. How does it impact by the EMS Compact? The EMS Compact, we are a member. I'm our commission designee. I'm also the chairperson of the Compact. And it allows people to go state to state without obtaining multiple licenses. And so it creates what we call a privilege to practice. Doesn't really create a new certification. The Compact cannot issue certifications, but it says there's basically an agreement that Indiana has by enrolling, says anyone from a Compact state can come here and practice, and we are not going to hold you responsible for practicing without an Indiana license. And so that's how that Compact works, is that privilege to practice. This is where we see a little bit of struggle, particularly with the Compact states, because it would be nice if we could gain those people and track them within our systems. But you cannot require a state certification because they automatically have that. But what can we do to streamline that certification so that they want to obtain their Indiana? There may be other states. I'll pick on Kentucky. It's the most notable at the southern end, where they charge for a certification. So there is a fiscal benefit maybe to not certifying with them. I would note we are landlocked. There's no other Compact state right next to us. And so we're most, we talked to Colorado and Texas some, we talked Tennessee is the most that we have transfer people, but Air Medical does utilize the Compact a lot to bring people in to cover shifts, things of that nature, that in the past were a little more challenging because they had to figure out how to get them Indiana certified, as we call it, or licensed. So when you look at reciprocity, to become an initial emergency medical responder, and I thought this was just a good education piece. I apologize if it may be insulting to some people, but it's a good reminder. EMR, we accept you 14 years of age or older. There are a lot of states that have young entry. We are one of the youngest with that. You must complete the commission-approved EMR course, and then you have to successfully pass a state written and a state practical. We do operate our own state cognitive or written examination. EMT reciprocity basically says then if you hold a valid certification from another state, or you took the National Registry route, that we would recognize you and you are eligible for reciprocity. When you get onto EMT, with EMT, you must be 18 years of age. So we go from 14 to 18, complete an EMT course based on the Indiana curriculum, which is basically a national curriculum, must successfully pass the EMT written and psychomotor examinations. So essentially all new candidates demonstrate minimum competency. And the way we have decided to do that is by taking the National Registry written exam and the National Registry recognized practical exam or psychomotor, which is really our Indiana exam that we have because the registry does not offer their own. So for reciprocity pathways, you see here that there are several. You have valid certification license from another state. You had equivalent training in the EMT curriculum. So we analyze that curriculum, and that's what we do usually with another state, see if the curriculum is compatible. Physicians are allowed to obtain an EMT through reciprocity. Note that a physician also has to still take the written and practical exams under the current practice to do reciprocity, and have completed a course equivalent to the curriculum. That could be, for instance, sorry, the first one was military. The second one is in general one that we can apply. And typically they would obtain a state certification in that state. But if for some reason they did not, they may be eligible to obtain their initial certification through Indiana. Hold a valid National Registry registration and note these. And when you get to the next slide, you can see it's more prominent that almost all of them add and successfully complete the EMT written and practical. So then we have them go through the testing process to show competency. And I guess the question in my mind, as I've talked to other people, is once you obtain and you pass that initial competency, that's kind of your pass through the door. You make an agreement to have a certification and can do your continuing ed. Should we make people retest when they actually, if we're recognizing other state offices, we're recognizing the National Registry, we're recognizing physicians, should we be making them take a written and practical exam? That is the slowest thing that holds up reciprocity applicants when they come in. I would note there is a provision, they can get a temporary. So we process a temporary where they can work for up to 6 months to get their formal reciprocity done. And so I'm like, we recognize it for a temporary, but then we still require that testing. And I guess that is kind of my question, and I want to hear from you, but I'll go through the other slides real quick. Really, is the advanced EMT and the paramedic are very similar, that you have to hold it as advanced EMT and still do testing. Paramedic is the same. You have to hold a paramedic and still do the, what I call the entrance testing to prove competency. And I guess my question is, isn't that valid certification from either the registry or another state proof that they have a demonstrated competency? And it doesn't guarantee, frankly, that we get a good EMT or paramedic. That is the provider organizations decide, you know, what their criteria are to come in. So that is my discussion for today. I think, you know, some things we could do with it if people agree that maybe we should. My main ask, I think, would be particularly with compact states. I don't think it's reasonable to ask them when they have a privilege to practice. I'd like to streamline as much as possible, but for all out-of-state reciprocity and national registries, I would like to see us get rid of the written and practical exams and accept those. The ways we could do that, we'd have to change those rules because those are from the rules. But we could do a general waiver like we do at the primary instructor until we get those rules waived. But I want to hear from this group, and certainly if anyone in the audience has any thoughts on this. So that is what I have, Mr. Chambers.
I'll start out. I'm still in the realm of that. I'm not a supporter of practical examinations now that we've implemented portfolios to begin with in Class N. We're like the last remaining bastion in all of healthcare that still requires that. I think we do overly well at making sure that students are ready in that arena. So I think to go direct reciprocity with no barriers such as written or practical examination.
Mr. Chairman, or actually Craig, so one of the other things just, and maybe it was in the slide and I missed it. So, and I'm supportive of this, don't get me wrong, but my question is are there not addendums to the basic EMT certification that have to be done on the CADIS before they can become certified? That's just post and so forth.
So we consider that part of the application process. So yes, they would still. And I think that is crucial for EMT because we do modify our EMT a little bit different than national curriculum. Not everywhere does a non-visualized airway. So I think it's important that we continue to have that part and they would still assign. But usually they can do those honestly in 4 to 6 hours. And so that's something they can do a lot more quickly than find a written or a.
Yeah, I was just wanting to make sure that was.
That is true. Yeah.
Okay. And then the other question I had there is I'm all for expediting this process. And I agree with Chairman Turpin that I don't think there's any validity to that competency aspect of it anymore because they're currently working. My question would be would it be automatic for someone that just wanted to get Indiana certification or licensure that is not actively working, but has a certification in another state, or would it be a requirement that they would have to be coming to Indiana to work for a provider?
So it depends on the level, if I understand what you're asking. So EMTs are not required to be affiliated. So they could, in theory, just seek a Indiana certification for purposes of having it. Advanced EMT and paramedic, part of that application process, well, it's the top line here on the screen that's up. You must have a paramedic provider affiliation or an advanced EMT. So they would have to have an Indiana employer that is willing to affiliate them.
Could we make that as a requirement for the basic also? I just don't want to see an influx of people getting Indiana certified and then they're dormant. That, you know, we've done all this processing for nothing because it's not benefiting Indiana anymore.
I don't think you could do it for everyone without a rule change because that would be changing the existing. I think if you were to say we feel waivers should be granted for reciprocity, you could say in the event they have a valid state license and they have an Indiana affiliation, then we would waive that written and practical. You know, if that is the route we were going, we could do it that way.
I mean, otherwise I'm supportive. I think we need to bring in as many people as we can, as quickly as we can, but, just so we're meeting the criteria as we've done.
Am I right in thinking that anything we do today would have to be a non-rule policy anyway until we change the actual regulation?
Sort of, yeah. The options today, I think you could advise us and then we do the initial waiver. So then once you say you support an initial waiver, then I can do a general waiver and subject to someone appealing it, it would apply to those applicants. But you could also, you know, look at doing a non-rural policy, but we usually don't do those till we have a written format. I think you had a question or comment from the audience.
So I just want to put out in our area at paramedic level, they're still required to test to do an EMS system. So it's not like there's not a standard that's being set somewhere. It is definitely by taking that rule away, they're still coming to us and they're still being required to test into our EMS system. So it's, again, it's not opening the door. So I think that is standards that we're still maintaining.
That is excellent point, because yeah, providers can put whatever requirements they are, they can still have them do all this if that's what they want.
And then the background check would also be included in this, right?
Yes.
So if somebody was in trouble with another state trying to get Indiana reciprocity because of leaving that state, we could catch it somewhere.
Yeah,
Like, hopefully,
it's a compact state, it's a little bit easier because they're in the database.
Any other comment?
I was waiting to see if there was anyone else in the room that had thoughts on that, since you're providers and how it impacts you all. Why?
Michael Wolf, Henry Nutritional Health. As somebody who has been a administrator from a EMS-based service, and as somebody who works for a sponsoring hospital and training institution, I support the proposal as it goes forward. I think it both brings or allows the possibility of providers to come in, we remove those barriers. But as a sponsoring hospital, we ensure that everybody that functions within our system meets the minimum criteria set by our medical. So as the other gentleman spoke about, we're going to ensure that anybody that practices within our organization meets minimum criteria through field internship precepting and through didactic testing. So I think the impetus is placed back on the providers, and you're allowing them to come in. But we also have EMTs that function within the state of Indiana that have an Indiana certification that may not meet our minimum criteria. I think we can weed out our own people. I think this can increase the possibility of having providers in our state, hopefully decrease the workforce impact that it has. I think that we're more than capable of taking care of what we need to take care of, and you as an administrative body can provide us the tools that we need to do to take care of that. And we can use you as guidance if there's an issue. So I as an end user, I support it.
Peter, do you guys do laterals in? Are you doing any of that?
Yeah.
But even if I was affiliated somewhere as a paramedic and then I lateral at Decatur, aren't you gonna, I'm gonna do my ride time probably, right? I'm gonna, you're gonna double check that, much like Superior, I think, spoke of, right? I mean, these are things, you're doing your own checks and balances for your.
Right, you, National Registry, right? Not just a state license.
Yeah, we do our due diligence and we make sure we are doing orientations and precepting.
Yeah, precepting again and evaluating.
We have a comment from Tom Fentress online first, and then we'll.
Good morning, everyone. I appreciate the time. If you guys don't recall, myself and Commissioner Zartman wrote a non-national registry policy for the state a couple years back, probably about 6 years back now, because we saw an influx of Illinois paramedics coming over to Indiana, but really they're having difficulties passing the national registry. What I noticed when that did happen was we had a lot of veteran paramedics coming over, 10, 20-year paramedics that couldn't pass the national registry because they never had to take it. So one, I am all in favor of this decision. But number two, I do want to put a little bit of cautionary tale on there that you definitely need EMS coordinators or medical directors who are holding these people accountable when they do entrance exams and entrance requirements. I know us at Methodist Hospital, we will be requiring anybody that comes as a national registry from out of state or compact state to have at least all 4 card courses or equivalents, because that's part of our requirements at the hospital. So again, I was just kind of voicing my opinion that I think this is a very good opportunity for us. I applaud Craig for you going out on a limb to do this. But I just wanted to kind of remind people that, you know, it's not only the new paramedics coming into the state, there are a lot of experienced paramedics that have never taken the national, don't know anything about it, and they failed more often than they didn't. And then we lost those paramedics because they did it once, they did it twice, and then they went back to Illinois. So it'd be nice to keep those paramedics in our state again. Thank you.
Try to, you know, because like me, I took national registry in 92. I don't have my national registry now, but you know, it is a little daunting. So I don't know if you said, we'll take you, but you got to take this. I might be like, it's not worth it.
Yeah.
And hopefully I'm a good guy.
I would follow what Tom said too. I believe and say also the provider has an absolute responsibility to check those people. Because the direct liability of it. So but go ahead.
I was just going to agree with Mr. Zartman that I know things last year and the year before, we did a lot of research as far as who was certified, who's actually working in the state of Indiana. And I was just curious how this would impact that study, because we were talking about, you know, how we're going to report out all the various positions and availability and coverage that we have. Obviously, having people out of state who aren't working here in the state would obviously cause some skewed data there. So I'd be concerned with that. So I do agree with the sense that I do think they need to be affiliated with somebody here in Indiana in order to have that certification or that license to work here. Because otherwise, I think you'll have people in Tennessee and Texas and some of these compact states that will show up in our database. And it's going to show that we have more EMTs and paramedics than we actually do. It's something else to think about.
For the compact, they have to have an affiliation. So even at the EMT level, they still have to have an affiliation if they're using the privileged practice part. So if we required that for the waiver of the practical and the written exams, it would be consistent with the compact.
So at this point in time, the proposal or recommendation is kind of only for those states that are compact states, and non-compact would not be eligible.
I was recommending, I feel like that's the minimum. I feel it should be every state. And I know the compact, we have taken a position for our database, for instance, we're making some moves and we hope to bring in non-compact states. And then the people that the advantage of a compact state, you get full rights in the database. A non-compact state that gives us their licensure stuff would have read only, but they would be able to pull people. And so I think I would prefer a national trend if it was me.
Yeah, and that's where I was coming from in regards to meeting all that other criteria, wasn't part of the compact
Yes.
side of things.
Yes.
Yeah.
Could you clarify for me again, the steps that an EMT would take who is coming from a state, for instance, that does not have supraglottic, non-visualized airways, training and background, what they would have to do to be able to do that here in the state?
So what we require them to do, what we've done for a long time is anyone that comes in, and even if we do look at what state they're coming from and what is the curriculum. And so we don't do any type of practical experience with them. They would do a CADIS training on airway in particular as one. But then if they have an affiliation, we would notify the affiliate. Just be aware, Michigan doesn't require non-visualized airway. I don't know if that's true. I just used it.
Then it'd be up to the provider to
Yeah.
make sure that they are.
And part of the reason we do that, I know I've heard before, I think we had another commission meeting, someone said, feel like the state's trying to push their thing on to us. That's not the intent here. I feel like the providers that are responsible are adept and they can do it more quickly than we can. So if they want to do written testing, they may still use the National Registry, but they may have their own test that they can do right now, just log someone on. And if they can do that, then I think that gives them more flexibility as an employer and helps move the workforce better.
So do we have anyone that was willing to craft that into a motion?
And I guess further, I think to the point too about an EMT having to have some type of. Feel like that. I don't know, you know, it throws a big wrench into it, but it's just another check, right? Let's make sure that.
Just a reminder, and I'm not opposed to this anyway, just a reminder as you figure out how you're gonna address this and figure out what, how you're gonna amend rules and whatnot, or waive rules. From a regulatory standpoint, we have to have rules that govern the lowest common denominator. So every provider that spoke about, yes, anybody comes into our system, we will test them, we will train, make ensure all that. Lowest common denominator provider is not represented in this room and has not spoken up and said, yes, I will do that. There are many of those that exist that gladly take somebody on without any checking up. I think Chairman Turpin mentioned, you know, it's essential that the provider is confirming those standards. If you're gonna put it on them, it's essential that we have some way to regulate that on the back end. Because if you just open it up and say they will, right, everybody here, everybody spoke up, most of the providers in the state will, but you gotta regulate to that lowest common denominator. And remember that there's a lot that just.
I think I hear what you're saying. I think you're saying there needs to be something documented that shows that there's a mandatory requirement that that's being done before they get testing.
How do you draft that? I also don't know exactly how to do it. Agree to have the affiliation for EMTs, I think is a must. But.
Sorry, I don't mean to disagree with my own staff. I think that's old school. You know, we always tend for the low denominator and then that holds back to high performing. If bad happens, they're gonna face a lawsuit and then we are also going to sanction them, you know, because they don't have their practices in order. So I think that would be addressed with the providers that don't act appropriately with hiring new personnel.
Is there urgency for us to make a decision today?
Not really. This is an ongoing, you know, just in the back of my mind, we didn't have a lot on the agenda. And so we started a new year and I'm like, okay, let's look at this and see if there is validity to this.
Could I make a recommendation that, a couple commissioners work with you and propose some kind of wording to present to the next commission meeting? That we can address all levels, advanced EMT, and paramedic, for a formal, proposal to the commission.
Yeah, I think we can take time to develop something.
We got a comment, Commissioner Hoggett.
I would be happy to work with another commissioner or two on this project.
Consensus of everyone, that's okay? Okay, so for chairman's direction, and just, give that to Commissioner Zartman, Commissioner Hoggett, with the assistance of Director Kenny, and
I can.
and
assist
good,
as
good
well.
point. Commissioner Maley with the air medical perspective, just scrap something for you back.
I think that's good. I think, your discussion and, we'll probably get into EMS 2025, but a lot of discussions right on how are we doing things right, but how can we help, certainly even at the EMT level, get more people through that program, right? Not compromising standards at all. And I don't disagree with Jason. There's probably, unfortunately, programs out there that don't do the things like Superior and some of these other places are saying. Oh, you want to come and work for us? Sign you up right now, and I'm sure that happens. Unfortunately, you can put all the checks and balances in the world, you're still gonna operate in that fashion. And Rick's right, the day will come, unfortunately, when it's probably an injury to further injury to a citizen, to a patient, in which they get in trouble for. But I think this is a good way to try to be better at this without compromising the standard, making things better in the state. So
And if we end up doing a non-rural policy or something of that nature, I think we can put some of that language in there, that is a caution. So then we have it in writing, the expectation of organizations.
A little bit further support what Jason said, it's like, I don't even put a brand new Indiana trained EMT on the street without going through non-visualized airway. But at the same time, we know that there are providers that don't even do basic OSHA training when they put people on the street. So it's a very good point, Jason. Okay, you'll be ahead with that small committee and look forward to your work next month. See, old business. Let's talk about the eclipse.
I asked to bring it up again, and then Robin's gonna talk about it because we do think it's a pressing issue. So a little quicker than last time, but we're still gonna cover the highlights.
Just want to go over some bullet points to make sure that everybody's thinking about it, planning about it. April 8th is the big day, Monday. Please make sure that you are participating in your local planning, your EMAs. Everybody should be having some local planning meetings. Please make sure that EMS is participating. If you want to do an agency planning, we do have a exercise in a box on our website. There's a whole website for total solar eclipse, and under the planning tab, there is a exercise in a box. Takes you about an hour to go through, just talk about different things. Great way to, I think, bringing those outside people in and get them thinking about stuff. Where your street people that don't normally see that part of it. Dr. Yeazel did his monthly in-service this month, I guess, same month, talking about it, but some of the things that we've been talking about, and I'm just going to go through these as bullet points. Think about alternate transportation, your gators, golf carts, bikes, and so on to be able to get, because traffic is probably going to be your number one hindrance on things. Already talked about your coordination with your EMAs. Look at your anticipated routes to your hospitals because of the heavy crowds. Think about patient care points or collection points so that you can hold patients, because you may not get them all transported to a hospital. Can you hold patients? Do you have food, water, whatnot, medications to be able to hold them for a little bit? Think about alternate destinations. Make sure that you're talking to those alternate destinations, make sure they're ready. If you have a county beside you that is not in the totality, maybe talk to them about a mutual aid handoff type thing so that you can get back within your community and let them handle those patients from there. Don't forget, eye injuries can occur 2 to 24 hours afterwards, so you may get that after the fact or Tuesday morning. Make sure to fuel your vehicles ahead of time. Think about alternate dispatch policies and maybe even think about a reunification plan if you transport somebody that's out of state, out of the area. Their family's here and you took one of their family members, think about a reunification plan. That's all I got. Dr. Azar, you got anything else you want to add to that?
No, just be happy to share my slides and my recording with anybody who wants more information, and basically just kind of brainstorming exactly what Robin said, some of the different issues that may arise. Went into some of the medical conditions you may see a little bit, some things like that. So happy to share that. And
I will comment that go ahead.
I thank Robin for that update. It's funny, I had someone call me yesterday and say, hey, we're just now hearing about this solar eclipse thing. Is this something that we really need to be, Joel, just tell me, I mean, is this gonna be a big deal? I think it's a big deal. And the things that Robin rattled off are things that literally, like Kentucky and Tennessee told us, this is what happened to us. And maybe they weren't as prepared in certain circumstances where the eye damage, car crashes later, like people just run off the side of the road all of a sudden. And they're like, what happened? And the person's like, I could all of a sudden couldn't see anymore, and it was hours later, and a lot of drug overdoses. I know talking to Department of Natural Resources, there's lodges, campsites have been booked up for years. They shared with us some details. So 48 states and 2 countries are represented just in their lodges and campsites. So people from literally all over the United States and around the world are coming to Indiana to see it here. And so just be prepared. Also want to include, make sure we're reaching out to our local health departments and our local hospitals. We've had discussion with hospitals, but making sure that there's a plan with the hospitals and the local health departments as well about this. And hopefully, people behave well in Indiana. They're like, I want to embrace the Hoosier values and we won't act inappropriate as we, but everyone's doing it. I drive out to Terre Haute and you see the billboards, Terre Haute's come to Terre Haute for the total eclipse of the Haute, I think is what they're calling it. So parties everywhere. Almost all of them involve alcohol. And then, you're going to be released to go home to learn traffic. So please take it seriously. Share, if you're having discussions, issues, whatnot, please reach out to us, our website. So we can make sure we make that available. Jason, you were just telling me, right? It's, we're 80 days away here. So from that, and our website has a lot of information on there. But yeah, please take it seriously. Please, and making sure that you're planning. Hopefully won't see that, but you plan and prepare and execute, you'll do well.
I forgot I was gonna add one more thing on it, for you guys, that we're hearing that a lot of the people that are planning events are asking for food trucks.
Yeah.
Who knows what you're gonna pick up the 24-hour bug after that, depending on how clean the food truck is. So remember that you may have that afterwards. That seems to be a big talk about right now. So.
And we had a large tornado outbreak in early April last year.
Yeah.
And so that's the other thing we're concerned about is, okay, you've got all these people, they're ready. And they're not gonna just drive to a location and be there at 3. They're gonna be getting in line. They'll be there all day for the 4 minutes of totality. And so toilets, water, those kinds of things. We want people to enjoy it. We want them to get out and do all the fun things, but making sure they have a plan is imperative. So thanks.
I'd just like to add, we've been watching our meetings in our area grow dramatically. Of course, being on the state line, we've been meeting with our counterparts in Kentucky as well. So it's kind of interesting to have meetings with 30 public safety agencies in them. But I think this representative federal government said it best. We have 24 cities in the nation that have populations of over 100,000 that are in the line of totality. This is going to be like having 24 Super Bowls at once. And if it's cloudy over one Super Bowl, we're going to move it once to where it's not cloudy. So the transportation issues are going to be huge as well. So any preparation time you spend will be time well spent. Okay. EMS scope of practice discussion, Dr. Hazen.
Yeah, if you guys remember from the last commission meeting, we were talking about adding kind of an addendum to the scope of practice checklist that we've used for years, just because there are some gray areas that come into it at the different levels of certification. And I went over a kind of an FAQ list that I'd put together last meeting. There was one issue that I think probably needs to be clarified a little further that I wanted to bring up from the last commission meeting. And one of the scope of practice we were talking about a few months ago, we approved intranasal glucagon. And then at the scope of practice thing this last time, we talked about a glucagon via an auto injector. Well, as I've talked it around the nation, not just here, those have really proven to be cost prohibitive. They're $600-700 for a dose. And I guess we talked about is the question, do we, number one, I think even for an auto injector, we probably need to have a formal motion to add that, since that's different than the auto injector for epi that we've approved in the past. And then also, do we want to consider allowing a draw up in the IM delivery are the two scope questions probably. Number A, are we okay with an auto injector for glucagon? B, are we also okay with a drawn up dose that way? Cost wise, it's much more, if it's, much more effective that way, and then I'll leave the debates on glucagon's efficacy to everybody else.
I have no issues on the clinical side of it because glucagon, when given, is fairly innocuous if it's not needed. But the only thing I'll comment, I think we just need to be aware of. I don't know how it affects our decision with it, but there's always that slippery slope on things that affects downstream. I know that currently wholesale price on glucagon, just the draw at 5% under AWP is $150. So it does take it out of the realm of ALS reimbursement. They would not that run to BLS unless you would hope there's some other skill in there, ECG monitor to still make that run ALS. In those cases for the ALS provider, but it does have an associated financial impact that's pretty significant.
Yes.
So, but again, if you're giving that, you should also probably have an ECG. I don't believe there's any direct.
And as I recall, this came from BLS providers, right, that were in rural areas that were concerned about long transport time.
And that's where, and I'll be honest, like I'm a little middle of the road on glucagon, but I do think that is the one area where that can make an impact. You've got when you're BLS, you've got 25-minute transport time, and you just don't have much that you can do to intervene in that scenario. And this would be a route to.
And I'm supportive of it. I guess my only thing is what we've done in the past. I think there needs to be definitely an educational module and some kind of a validation process, since it's not really part of the scope of practice, and that you're allowing them to now do that. I think there needs to be some kind of a check and balance there. And what that is, I don't know, because as Jason said earlier, each provider is going to be something different. So is this something that we put on CADIS and they have to complete, it's by some point in time or whatever. And then, from the educational side, then it has to be brought into the basic EMT course and part of that portfolio. So just food for thought. I just think there needs to be a check and balance for medical control.
I would note that the technique is covered, we both have both auto injector and IM on the EMT level, and I believe they are included in trainings, but yes, we would not have anything currently that covers glucagon. So
You see the,
Andrew Bolton.
Hi, thank you. Is there a cost prohibition since we've already approved the nasal glucagon? I see online that costs about $300 per dose. It is very shelf stable. Again, I'll announce my conflict. I was part of the work team in Germany that kind of explored nasal glucagon. So is there a cost prohibition as why agencies can't use nasal glucagon that we've already approved?
That's the response I have from places that they aren't utilizing it for cost reasons.
yeah.
sorry, it's minimized because.
Oh, it says, if we're considering glucagon at the EMT level, can we consider PO aspirin at the EMR level for ACS?
Maybe how about submit that one for a discussion on another day.
Okay, I'll let them know.
unless, so it's a strong problem. Yeah. And I'm all for the scope of practice discussion, but that's what happens sometimes is one thing begets another, which is great. I want to have that dialogue, but also this could go, into the weeds pretty quickly and, so I think that's a discussion for another day probably.
And I have told Dr. Yazel, I don't feel comfortable because this is directly in the scope. We have said only the commission can change it. So I don't think it can go in his comments. So I think we need a yay or a nay so we can advise providers, on this and on our scope. Our staff position is we think it could be beneficial for providers, but we understand their cost as well. So I think we are supported, but not a hard supported.
I guess I'd like a little bit more information on shelf stability. How long is the nasal valid for versus the draw?
Yeah.
And there's a difference in cost,
Yeah.
but if it's gonna be used rarely, does that cost offset
So
based on the need?
makes sense. Yeah, and I don't know that answer, to be honest with you. Andrew May, he said, as far as the nasal,
I know there was a discussion at NAMSP 3 years ago regarding a lot of providers were ceasing to carry glucagon and were simply going to EZIO and D10 just because it was $30 cheaper than giving glucagon. It's fairly invasive in my opinion,
yeah.
but they were actually doing it just based on the cost.
That's what I can do too, is I agree, I can do like a quick cost analysis or something like that and table it around and say, hey, this is what the costs and benefits of what we're looking at and go forward from there. I think would be a reasonable way to take that too.
Could we also include that education
Absolutely.
component?
Yeah, it seems to make sense though, really. I mean, they're already doing IM. And glucagon it might make some people puke once in a while. You see that, but who cares? So it's very easy to give. They're doing exactly the same thing that they're doing with Epi. They just need to know how much to grow.
Would this be a medication that's then going to be required of all BLS transports, or is this going to be left up to the medical director and the organization to determine?
I believe all of our medications are pretty much up to the medical director, so it'd be up to local medical director. All of our recent ones are at least.
And I think you will see some variance there. I think there are some philosophies kind of across the board there.
And the reason we ask for the medical director is because of that ongoing supervision to make sure, because we don't want a medical director to say, I didn't want it, but they did it on their own. And then they don't properly supervise and they need to make sure it's being used effectively and appropriately.
Just to toss it out there as a part of this whole IM thing, at NEMSD this year, there's a really good study presented that showed that 5 milligrams of IM epi cardiac arrest increases survival over an initial dose of IV. Their emphasis was BLS providers providing that, and they were seeing a substantial increase in survival when it was given early, because it was given early by PLS, people were able to stay out there. So, not that I'm proposing that right now, but this whole IM thing is probably gonna expand.
Well, that's right. When I was talking about questions beget question, I think, and that's okay. I'm all for looking at that, but yeah, I think you're right, that there's probably more questions on the horizon.
Yeah.
Does someone wish to craft this into a motion?
I don't know if you need a motion, because we haven't requested. So, I think you asked for more information, so I think we can just bring it back.
I can prepare like a little one pager for next time, since this is what we looked at, and then we can make a motion off of that maybe.
Go ahead, Andrew.
Yeah, just some info that I pulled up from my notes from that Eli Lilly conference. So nasal glucagon is stable on shelf for 2 years, not exceeding 86 degrees Fahrenheit. The glyco kit or the glucogen kit is shelf stable for only 18 months, not exceeding approximately 76, 77 degrees Fahrenheit. So there are some discrepancies, or there are some differences in shelf stability, with nasal glucagon being more stable over long term over the pre-filled kits.
See, Dr. Brown has her hand up.
Okay, Dr. Brown?
Yeah, I was just wondering if we might want to consider looking at our EMS run sheet data for the state and identifying of transports that are performed with BLS being the highest level of care. How many of those have documented hypoglycemia, to just really understand what the impact might be.
I think we could try to do that. We'll try to do that as part of our research as well. Good idea.
We shall research that and come back and discuss. Administrative proceedings.
You have, in front of you, it was not busy, over the holidays. But we did have one substantial one that's in there, which is a revocation of a paramedic license, EMT certification, related to, a controlled substance diversion. And we did have one provider, for a late renewal. And then an appeal update. We had a case there of Gerald Simpkins. That one ended, it was under appeal, ended in an agreement that was approved by the ALJ. There were extenuating circumstances, and so that's why we entered into that agreed dismissal. No action.
On the staff reports, data registry, Amber Foster.
Hello, everybody. I have three things basically to report on. 2023, our EMS reporting reached 99.7%, largely in part to my summer intern, Anna Settle, whose assignment was to contact every EMS provider and try to get her reporting numbers up. And it worked. So excellent news. Fire reporting is up to 77%. 2 years ago, it was about 40%. And I want to report that our NEPSIS version 3.5 run form transition has been successful. We anticipated some glitches and problems. We worked through all that. It's been adopted as of December 1, 2023 in Indiana. One change that NEMSIS made was they are going to continue to accept 3.4 run forms until June 30th. So we will also continue to accept 3.4 until June 30th, at which time we will press the button and no longer accept 3.4 and only 3.5. Very questions. Thank you very much.
Operations report, Bob.
Just one really easy thing. I hope it's easy thing. January, we got lots of new people. So if you have a fire department that's certified EMS, ambulance service, and lots of new chiefs, new EMS chiefs, all of that, please make sure that you're getting with field staff and getting those notifications to us of who the new people are in changes so that we can add them, get our database updated, as well as getting them on distribution lists so that they get commission meeting info and everything needed. So that seems to be the big one right now. That's it.
Certification compliance. So we ended the quarter, December 31st, and you can see the numbers there. It was a similar quarter to the last one, and renewals, and then the percentages there of the people renewing that were eligible are fairly consistent with where we've been before. So that is not surprising. So December 31st, 24,541 clinicians that are out there, certified persons. And during that period, 16 audits, and we had 0 sanctions. I think we have 1 pending early this year, but not during that period. Violation statements, 34 individuals checked yes in the system, 12 have been resolved, 22 we need additional information. 7 have pending criminal cases, and none are pending a team review for a sanction. So that is our certifications report.
EMS Education and Training Report, Carrie Lynn.
That's actually me. Carrie is on a cruise, so we can all give her grief later. They did have PI quarterly update. Attendance was very good. They continue to grow. So if you're a primary instructor, have not participated, do so. If you're involved in education, it's mainly for the instructors, but you can ask to get those invites as well. We will do them again quarterly. We just did January. She noted that we are meeting with John on February 5th to go over the psychomotor exams and get those on track. I do want to clarify, John said we had a meeting, and if there are education oversight committee people, that's not a committee meeting. That's a preliminary meeting to try to create some work product to go back to that committee. Those changes for the advanced EMT need to be done by June 30th. At the quarterly meeting, they did, one of the things we asked for input that will change a little bit is the assignment of courses in classes. When we do that in ACADIS, we've done that a couple of years, and it helps some because it shows up in the class, but the instructors can't always see it. And then it also creates challenges because if a student doesn't do the assigned class course, but does the same course outside, ACADIS doesn't recognize that. So then they call in saying, I did it. Then we either have to manually confer it or they retake it. And it's been a little bit of a nightmare. And so we asked the primary instructors, what do you think about us requiring this as part of their certification, but keep it out of the classroom part? If we do it through, we confirm it when they certify, then that makes it easier on us. And we see anytime they've taken it, whether in a class or not. And so that is really going to streamline. And so the instructors on the phone were overwhelmingly supportive. So we do look for that change for courses coming up. I think that's all the education updates right now.
EMS Director Report, Director King. Again.
Yay. The first thing we have is staffing update, and I want to recognize Mr. Stan Frank has a birthday today. So I have to do my due diligence and recognize our staff as a birthday. So happy birthday there. Indiana EMS 2025. We looked at some logos, by the way. So I'm hoping by next meeting, I'm going to have a logo to share with you on that. As again, that concept stakeholders, we do have commission members. Your commission members on there are the chairperson, vice chairperson, Darren Hoggett, and then Andrew Bowman. But we have had good turnout from all of the stakeholder partners, excellent discussion. And our goal is to kind of create that white paper of what recommendations we have to improve EMS on a variety of levels. The 6 main categories are there. Safety, we have heavy discussion. We're still funneling out those recommendations. Last meeting yesterday, we went over EMS education and career pathways. And again, excellent discussion, and we're going to have some recommendations out of that. We do have a meeting coming up on February 14th, Valentine's Day, hosted by the Indiana Hospital Association. That will be a all-day meeting, 10 a.m. to 4 p.m. At the Hospital Association, and we're having lunch with the EMS Association, providing thank you. And we're going to go over funding and essential function, and then we will tie up with the EMS workforce in March. And so that is progressing. Again, very positive, hopefully can produce some information for you there. There are a list of future meeting dates. Again, we have committee members when we get to voting, but we welcome input. So if anyone would like to participate virtually or would like to attend in person, there are the meetings and we can get you the actual invites. Health First, that we also have a logo for that. And I just did preliminary approval yesterday. So hopefully we will have that for the next meeting. That is what we're, Health First is basically the Governor's Public Health Commission recommendations. And then the funding is EMS readiness. We have the roughly 6.4 million for equipment training, instructor development. The big one we're doing right now, we have done the training that is to be done of new EMS certified personnel. Now we are on the second major project, which is training institution equipment grant, and Stan is spearheading that. We do have around 31 requesting about 1.5 million. We have a little bit over $1 billion to give on that. So be competitive, but hopefully we can reach a lot more of the list than we were able to on that first grant cycle. We hope to have announcements on that in early February. We had a good meeting yesterday with our Department of Administration, the fiscal people, and they were going over our bidding and other processes. So I feel like we're going to make some progress. That's been the delay. It is not Dr. Gazel. He has a good program on Rapid, but we're going to get that updated with their recommendations and get that bid out. And then student test prep packages for EMS students was discussed as well. CADIS funding will fund that continuing education model. They were renegotiating the CADIS contract, so I just need to find out where it is. When we have that and we get that module, of course, we will be demonstrating for the commission, and we'll also share that information with everyone, because I think that's going to be a very nice upgrade that people have asked for a while. Instructor development, we still are talking with Nancy and need to pare that down. We do have one first class that Carrie was able to get listed that is coming up, and it is actually full with 30 people, and they are almost all primary instructors because it is a class offered to the fire service. And so they have said, if you can't fill the minimum seats, we can backfill some of those for you because it's a popular class. We had enough EMS sign up that we filled the class. So we may look at a second leadership class from that because it is so popular. Bowen Center, only update there is our report. I looked at preliminary. I think it's going to be interesting data, and that should be dropping anytime it's with their graphics people to try to get that finalized into us. We have our own annual report that'll be updated for 2023. We have gathered all of our data and staff reports. I've submitted it to our public affairs. We're targeting mid to late February to get that released. And so that will probably be covered at the next commission as well. I usually go through that. We are planning for EMS provider forums this year. So we will be out in the districts. Right now we have Made, Huntington, and Francisca and Lafayette. We do have districts 1 and 2. Thank you. I know Gary had reached out if we need help. We have a confirmation there, and that will be at here. That will be on, I think, I got to confirm. I don't want to say which date. I think it's the 30th. But we are going to be in LaPorte for that one this year. And so we will get that location added. Once I get all of the confirmations, we'll create a nice flyer. It'll go out, and that way people can do that. Hoping there's enough time to get good information there. We are looking for feedback from providers in general, commission. If you on topics, we do the forum in the morning, which are our updates. But in the afternoons, we've tried breakouts for different discussion topics. We also have done a live leadership course. And so I think that's something that we could do as well, if that is something that there's interested. So please give us feedback for what you want, because we're bringing the resource out to communities, but we want to know what you want us to bring. Hamtevy, we are getting closer. We still have the split there, the cost share coming up. That is in contracting right now. We have a draft agreeable to both parties. It is, we're waiting on approval for the procurement part of it. So I'm hoping we'll have an announcement, hopefully before, but at least by the next EMS commission meeting. State IDOH had been on, I'm sure they would have promoted. We again have Public Health Day coming up on Thursday, February 22nd in the State House. And they recommend that you consider attending and participating because they want EMS involved as well as all other healthcare professions. And so I would encourage you to consider participating in that. There are a variety of days, by the way, because I think it's next Wednesday. The fire chiefs have a day there as well that we will be attending. National partner updates, EMS Compact continues, have a few good meetings. We have a few prospects for improving how we operate and streamline it. So I think it'll be a productive year. And since so I did attend the annual meeting, which was held out in Alexandria, Virginia. We are doing a lot of work on advocacy, and I think that will continue this year. I think the regional in-person may be back in Indiana. We hosted it the year before. Last year in October, we went to Michigan. Illinois and Ohio have said they might want to do it. They just don't think they can do it that soon. So I think I'm going to do it this year so they can monitor how I do it and make them more comfortable for future years. National Registry of EMTs, we have November board meeting. No earth shockers out of that, I don't believe. And the only reminder I have from that is that July 1st, 2024, that is that transition date when the exam changes. And it is not only still adaptive at the paramedic level, but it includes the motor aspect by asking analysis questions related to practice. And so with sent out a lot of notice. So if this is shock to you, please see Carrie or myself, because you need to be up on it. You may not want a student to test, say in June, if they're going to still be retested, because essentially, let's say that they passed their written exam, they still need to finish the practical. They take it in June, they can't find a practical, July 1st happens. Their only option is to take that exam that combines both. So then they're probably going to be frustrated that they already took the cognitive or the written. Now they have to take the expanded cognitive, but that is the way it is. So just be aware, if you are not, then make sure you see a staff member so you can get up on that. National Association of EMT, AAA, still involved on national advocacy efforts. So if you're looking for ways to be involved, our local efforts, we still support the Fire Chiefs Association, the Volunteer Firefighter Association. I did relay that we are willing to do the roundtable in their conference. They have been very supportive as well. And then, of course, the EMS Association is a great partner, and they have a meeting right after this as well for their members. That is what I have, unless people have questions. Again, I can email that out.
Questions for Greg? Yeah. On to state medical director's report, Dr. Yes.
All right. As per usual, most of my stuff's already been covered, but we have a few things to update. Let me talk about the rapid team proposal, the inter-facility transfer pilot that Craig mentioned from the Health First Indiana funding. It's coming. There's just a lot of delays because there's a lot of moving parts to this. When it does come out, I do also anticipate a lot of questions. And one thing we'll probably do is have an official information discussion, maybe after state in service 1 month, to to be able to answer all those questions, because we do want a good, strong pool of applicants, because I think this has a really big potential in our state. So just stay tuned there. We'll keep you updated and things like that. I did mention state in service, getting to where we're consistently at about 100 people. So I think that's great. Would love to see, that keep growing each month. And also would love to hear more about what's going on out in the state. So if any of you guys have topic ideas or want to present something you're doing yourselves or anything like that, please reach out. Also using that as a way to kind of keep the state connected with, upcoming conferences and legislative updates and things like that. So also please reach out to me if you have any information that, you want me to share on your behalf out there. We want to get as much out there to everybody as possible. So appreciate the interest level there. We just talked a little bit about mental health support for first responders. There's been some legislation. There were some bills that were introduced a couple of years ago. There's some now, and I think you'll continue to see that moving forward. And probably not formal enough to call it a task force, but there's a group of us that have been working together to kind of talk about what best practices are for mental health support for our first responders. Some pre-employment, counseling and support, peer support, Project Echoes, where that's kind of a virtual monthly meeting where people kind of come and talk about different things going on and decompress. The other virtual options, in person through employers, all those kind of things. Critical incident stress management. One thing I always grumble at is a lot of the educational offerings down my way are poorly attended. I think we have a CISM class that was sold out, wasn't it, down in Scottsburg right now, or darn near it? So standing room only. So excited, really, really excited to hear that. So I think you're really going to see some movement there, and we want to make sure as that moves forward that we're doing things that are impactful, not just, modules that everybody's checking through just so they can, cross something off the list. So certainly open to any input there, and we'll keep updating you that way. Kind of along the same behavioral health side of things, we're getting ready to start a major data project on the behavioral health transfers. I know that's one that's been a challenge for a lot of the services across the state, both, the volume, the time of day they go out, length of the transfers and things like that. On the emergency department side of things, you're seeing 36-hour ER stays waiting for a bed, things like that. We all know it's a problem, but you're just so much more effective when you have concrete data to say, this is what's happening out there. Here's the numbers, here's the impact and things like that. So excited to get that project underway. Really lastly, I just want to thank our staff. I get out in the state a lot and I just hear so many comments about how hard our staff works. Our district managers are always available. And, a lot of us have been pulling double duty, trying to implement some of these grants and things and do the day in, day out tasks and things. Craig's been coordinating the EMS 2025, all these grants. It's just a lot, and they've really been doing a great job. Our certifications, I used to go out in the state and somebody always sideline me like, hey, can you check the paperwork? I don't hear that anymore. So just want to thank everybody because they're working really, really hard, and it's noted and appreciated. That's all I got.
Any questions for Dr. Hughes? Seeing none. Assignments, staff is to look into the glucagon and have some information on that. We have our other one that will be studying reciprocity issue whether they want to test. So those will be discussed at the next meeting. Chairman's report and direction. I honestly do not have a lot other than to mirror what so many people in the room have already said. If you're not taking preparations for April 8th, please get your groups together in your areas and do so. There's a lot to be looked at and a lot of contingencies to be put in place for it if you're in the packet. So our next meeting will be here at Made, 1610 Reeves Road, March 8th at 10 a.m. This being the end of the agenda, I will entertain a motion to adjourn.
So excited to get back out in the snow.